probably the most well-known type of call that a paramedic will run is the cardiovascular emergency. And sure, that's kind of a general term, and it encompasses a lot of different types of pathologies and calls, but it's certainly the most critical of those calls. You can make the argument that traumatic injuries are critical as well, and they are, but the cardiovascular emergency is going to require more of your paramedic skills. It's going to require more of the advanced modalities that you're going to learn in paramedic school. And in these next few videos, we're going to kind of give a comprehensive course on the cardiovascular emergencies chapter and cover many of the different topics that are covered in those chapters. In addition to that, you're going to have several modules on EKG interpretation and 12-lead EKG interpretation that you should complete as well. So the role of the paramedic was actually created more than 40 years ago to provide early treatment for patients with acute myocardial infarction, a heart attack. And that's actually why the paramedic exists. An AMI occurs when sudden narrowing or complete occlusion of a coronary artery causes a myocardial tissue necrosis or cell death, tissue death. The American Heart Association actually estimates that one person has an AMI in the U.S. about every 40 seconds. It's pretty significant. Cardiac arrest is the cessation of cardiac mechanical activity as confirmed by the absence of signs of circulation, including a pulse. In the United States, emergency medical services, or EMS personnel, treat about 60% of all out-of-hospital cardiac arrests each year. All right, so I specified mechanical activity. So cardiac arrest is the cessation of cardiac mechanical activity because they could still have electrical activity. We know this, right? With pulseless VTAC, ventricular fibrillation, and any pulseless electrical activity rhythm, you still have an electrical functioning heart. However, there's no mechanical activity. There's no blood being pumped out producing a pulse. So once again, whenever we talk about cardiac emergencies or cardiovascular emergencies, it's going to be important to do a quick A&P refresher. And we're going to talk about the structure and function of the cardiovascular system and how it's composed of the heart and all of the blood vessels in the body. So, of course, when you think of the cardiovascular system, you think of the heart, but do you think of the blood vessels in the brain? Because that is certainly part of the cardiovascular system. The primary function is to deliver oxygenated blood and nutrients to cells in the body. It's all about energy production, right? So getting oxygenated blood to all the cells of the body with glucose as well will help to create ATP. We know that's where we get energy from, and that's pretty much all of our functioning is in an effort to create ATP. It's responsible for delivering hormones. It transports metabolism waste products from the cells to recycling or waste disposal sites. All right, so here we have the heart. Okay, you should be pretty familiar with this image. The heart has 4 chambers. We know it has the right atrium, the left atrium, the right ventricle, and the left ventricle. And you should also know where each of those chambers pump its blood to. The right atrium actually receives blood, low in oxygen, from the superior and the inferior vena cava and the coronary sinus. Okay, so that right atrium receives the deoxygenated blood. The left atrium will receive freshly oxygenated blood from the lungs by way of the right and left pulmonary veins. The atria then contract, pumping blood through the AV valve into the ventricles. Of course, the right ventricle pumps deoxygenated blood to the lungs, right? So on the right side of the heart, there's a little amount or no amount of oxygen in the blood. So where does it need to go? To the lungs to get that oxygen. The left ventricle will actually pump oxygenated blood throughout the entire body. Okay, so all of the different parts of your body that are going to receive oxygenated blood are very dependent on that left ventricle providing enough force for it to get there. When the left ventricle contracts, it produces an impulse palpable at the apex of the heart. This is your apical pulse. It's also called the point of maximal impulse, or the PMI. A septum separates the right and the left sides of the heart. The interatrial septum separates the right and the left atrium, and the intraventricular septum separates the right and the left ventricle. These septa separate the heart into two functional pumps. You have the right atrium and the right ventricle composed of one pump, sometimes called the right heart. It's a low-pressured system because it's only sending blood to the pulmonary circulation, which is the lungs that aren't that far away, right? Remember, the heart sits right in between both of the lungs. It's pretty close. Whereas the left atrium and the left ventricle compose the other pump, and it's sometimes called the left heart, respectively, and it is a high-pressure system because, again, that left side of the heart has to pump blood throughout the entire body, the systemic circulation. Of course, your heart has three layers, and in the middle is the myocardium. It's comprised mostly of thick cardiac muscle, and it's responsible for cardiac contraction and efficient ejection of blood from the heart. So that thick myocardium is what we need to send that blood to both the lungs and to the entire body. Of course, we know since the left side of the heart is pumping blood at a higher pressure, the left side of the heart has a thicker myocardium. It actually kind of dominates most of the heart size, that left ventricle. And myocardium is also in the phrase acute myocardial infarction, so that means an infarction of the myocardium or death of the tissue of the heart muscle. So when that happens, then of course your pump isn't going to work as effectively. So there are two main coronary arteries that supply blood to the tissues of the heart. You have your left main coronary artery and your right main coronary artery. The left main coronary artery, or the LMCA, is the largest in diameter and the shortest of the myocardial blood vessels. Okay, the largest in diameter and is the shortest. It divides then into the left anterior descending artery, or the LAD, and the left circumflex artery. The areas supplied by the coronary arteries differ among different people or patients. Some people will have a wraparound circumflex or a smaller right coronary artery. So there's generally some things that you'll appreciate or understand amongst all people, where the LAD is a pretty important vessel amongst all people, but there's also some differences. For instance, the circumflex artery actually supplies the left atrium and part of the lateral surface of the left ventricle, the inferior surface of the left ventricle in about 15% of people, and the rest of them, that inferior wall is actually going to be supplied by the LAD or the RCA, the right coronary artery. The left circumflex also provides blood to the posterior wall of the heart in about 15% of people, where in the other 85% it's provided by the RCA. So when that happens, it's called the left anterior descending artery in the back. And whenever the left circumflex is the one that supplies blood to that artery, it's called a dominant left circumflex. And when the RCA, the right coronary artery, provides blood to the posterior descending artery, it's called a dominant RCA. That LAD that we talked about, that's the big blood vessel that comes from the left main. That supplies blood to the anterior surface of the left ventricle. Remember that left ventricle is a super important part of the heart because it pumps blood throughout the entire body. It also supplies blood to part of the lateral surface, helping out the left circumflex, and a portion of the intraventricular septum in most patients. So when you have an LAD occlusion, that's a pretty bad MI. And they call the LAD the widowmaker for that reason, because you can go into a lethal arrhythmia pretty quickly. Now, the right coronary artery, it has branches that supply blood to the walls of the right atrium and the right ventricle, a portion of the inferior part of the left ventricle, and portions of the conduction system, such as the SA node, because we know that's in the right atrium, so it's on the right side of the heart. The SA node in about 60% of people, and the AV bundle in about 85% to 90% of people get blood from the right coronary artery. So when you have a right coronary artery occlusion, your dysrhythmias can be prevalent because you're not supplying blood flow to those pacemaker sites that we normally use. So, of course, pictures help us to understand this a little bit better. Here on the left side, this is the posterior wall. I'll just write post. And on the right side, this is the anterior view. Okay, it also says it on the bottom here. I just noticed that. All right, so look first at the anterior side. Let me change this a little bit. And on the anterior view, let's bring that forward, you can actually see, okay, where the coronary arteries come out of the aorta. So this is your aortic arch, okay? This is called the ascending portion, and this is called the descending on this side, and this is the arch. So right before your ascending aorta, or right after the aortic semilunar valve closes, blood will come back down, and this is where those vessels come out. So actually, those blood vessels, the coronary arteries, receive blood flow during diastole. When that aortic semilunar valve closes, the blood that comes back down the aortic arch will actually provide blood to them. So over here, we have the RCA, and that comes off the base of the aorta, and this is called the coronary sulcus in the heart. Then it comes down here, and it provides blood to this marginal branch, and then it might wrap around in about 85% of people and provide blood flow to that posterior descending artery we were talking about before. Now, let me just switch colors here. Over here, this is called the left main coronary artery. You notice it's pretty short. It starts right about there. It's behind this pulmonary trunk, and then ends right here. That's the left main coronary artery, and it branches into these two large arteries. This one over here that goes around to the lateral side. This is the lateral side of the heart. That's called the left circumflex. Okay, so the left circumflex is going to provide blood flow to that lateral wall, the left ventricle, and also in about 15% of people, it'll wrap around to the posterior wall. And then here we have the left anterior descending artery, or the widowmaker, right? You can see it's descending, it's going down. It's anterior, it's on the front, and it's on the left ventricle. So this provides blood flow to the ventricular septum, to the whole left ventricle here, the apex. So it's a pretty important part of the heart. Again, looking over back at the RCA again, I should mention this is the inferior wall. Okay, this flat part right here is called the inferior wall of the heart, and that's going to get blood flow usually from that RCA. So inferior wall MIs will often be an RCA occlusion. Anterior wall MIs will often be an LAD occlusion, and lateral wall MIs will often be a left circumflex occlusion. So that's important to remember. So now let's look over here at the posterior side of the heart. And what's important to identify here is this posterior descending artery right here. I'm just kind of putting dots there so I don't cover it up. That posterior descending artery provides blood flow to the posterior wall of the heart. And I said, again, about 85% of people, it's going to get blood flow from the right coronary artery, and about 15% of people, it's going to get blood flow from the left circumflex. And sometimes we even have what's called an anastomosis, where it kind of connects from both sides right there. And that's probably the optimal choice if you had a choice, because if one side gets occluded, your posterior wall will still receive blood flow. So kind of think of how this would happen in an evolutionary state. Let's say if you had an RCA occlusion. Let me clear all this here. If you had an RCA occlusion, which is right here, this is the RCA, think about what parts of the heart might be affected. Well, certainly the inferior wall, and this right ventricle could be affected, and the posterior, and most people, could be affected as well. And if this is the furthest away part of the heart, the posterior wall, then that's going to be the first part to show changes. So when you start to learn 12 lead EKGs and how you would identify posterior wall infarcts, that might be the first thing you see with a right coronary occlusion. Then you'd see maybe an inferior wall, maybe the right ventricular infarction, and all of those things. So it's important to know that your cardiac cells have 4 important properties that help the heart function efficiently. Okay, they have automaticity, okay, which is they'll work automatically without any initiation from anything outside, anything else. They'll just work autonomously. They have excitability, which means they can take impulse from the outside. They have conductivity, which means they'll transmit from one cell to the next information, or conduction. And they have contractility, which means they can expand and contract. And we know that, right? Because the heart is a pump. And the cardiac conduction system is comprised of 6 parts, your main parts. So you have the sinoatrial node, or the SA node, and that's typically going to be your pacemaker in most people, and it has an intrinsic firing rate of 60 to 100 beats per minute. All right, so that's why normal sinus rhythm is 60 to 100, or your normal heart rate is 60 to 100, because it's coming from the intrinsic rate of the SA node. Your AV node is actually, it's not really usually considered a pacemaker. It's actually an area of tissue between the atrium and the ventricle, hence AV, atrioventricular, that slows conduction. And the reason it slows conduction is because as conduction is moving from the SA node to the AV node, right, and then it wants to go to the ventricles, well, remember that this is causing depolarization, which is causing contraction. So the atria are both contracting and trying to expel blood into the ventricles. And this AV node allows for a little bit of a pause, okay? It allows for a pause so the ventricles can fill up with blood, so the atria can eject all of its blood. So that AV nodal pause is actually super important for that Frank-Starling mechanism, right? The more the ventricles expand, the more they contract, the more, cardiac output you'll have. So the AV node actually has an intrinsic firing rate of its own, usually about 40 to 60 beats per minute. The bundle of His is kind of in this little picture I've drawn. It's right here. It occurs right after the AV node, and together the AV node and the His bundle, or the bundle of His, is considered the AV junction. So all of those together are kind of considered your AV junction. And all of that area is where an AV block can exist. So an AV block can exist both at the nodal area, the AV node, or the His bundle. And then you have your right and your left bundle branches, okay, and then they go to the ventricles, okay. Your right and your left bundle branches will actually provide conduction to your ventricles, and your ventricles have an intrinsic firing rate of about 20 to 40 beats per minute. Depending on what you read, sometimes it says 15 to 30 in some books, but if it's slow, basically. So an idioventricular rhythm would be bradycardic. All right, and then after your right and your your right and your left bundle branches split, they end in these things called Purkinje fibers in the ventricles. And that's the last part of the conduction system to depolarize. There are other parts of the conduction system. For instance, you have Bachmann's bundle, which conducts. When we're talking about the conduction system, all the cells in the endocardium are going to conduct, but the conduction system is those very specialized cells that are really fast. It's kind of the highway of the conduction system, and everything else is the back roads. So you have another piece of highway here called Bachmann's bundle that takes the conduction from the SA node over to the left atrium. So the right and the left atrium will conduct almost simultaneously. That's why you have that Bachmann's bundle. You also have intranodal pathways that connect the SA node to the AV node. They're called intranodal pathways. So there's all those different parts, but the main parts are, the ones I just discussed here. So we kind of talked about excitability, and that comes from the sympathetic or the parasympathetic nerves when they're stimulated. Stimulation of the sympathetic nerves will strengthen the force of contraction, right? That's your adrenaline system or your adrenal system. And it increases the heart rate. We know that, right? Adrenaline, epinephrine will increase the heart rate. So the sympathetic nervous system is going to always provide an increase in force of contraction or an increase in the heart rate. And then the other part of your autonomic nervous system is your parasympathetic nervous system. And it slows the rate of discharge of the SA node. Remember that vagus nerve is going to innervate at the SA node, at the atria. It's very much involved in your atrial conduction. Okay, so that's why parasympathetic blockers will help with atrial bradycardias. We'll talk about that in the EKG lessons. It also slows conduction through the AV node, okay, and it weakens the strength of atrial contraction. Notice most of this stuff is all supraventricular, but it can also cause a small reduction in the force of ventricular contraction. That's because it to a much lesser degree, the vagus nerve will innervate the ventricles. So let's talk about your patient assessment and your primary survey. In the patient assessment, the common reasons to seek medical care, right, are a patient with cardiovascular related symptoms, They may be young, middle-aged, or an older adult. All ages of patients can present to you with cardiovascular symptoms. And a systematic approach to the patient assessment is important. So being systematic or methodical, if you will, with everything you do is going to help you to avoid mistakes or error or missing things, right? Because if you're systematic and you approach every patient the same way, you're likely not going to miss things as much as if you kind of jump around from one thing to the next. Your primary survey, the order of the steps for performing a primary survey differs depending on the type of cardiac patient. Okay, so you do want to be systematic, but you may move around your order because of, maybe something is more critical and you want to move to that rather quickly. The order of steps in the primary survey is normally if the patient is found unresponsive and is suspected of being in cardiac arrest, the order changes to your CABDE, but it's normally going to be your ABC. So if your patient's unresponsive, you're going to check for a pulse first. If they're responsive, of course, you check airway first. So that's the difference, and we know that from the American Heart Association and from CPR. So taking a patient's history that has a cardiovascular emergency, remember that your acute coronary syndromes are a series of cardiac conditions that are caused by an abrupt reduction in blood flow through a coronary artery. So there's many different types of patients that can have ACS, and there are three major ACSs, or acute coronary syndromes. The first one would be unstable angina. That would be a consistent angina that doesn't go away with your regular at-home treatment, such as sublingual nitro. And then you have your non-ST segment elevated myocardial infarction, or NSTEMI. That doesn't mean that they're not having a STEMI or not having an MI. It literally means that they're having an MI, but it's not presenting with ST elevation on the 12-EDKG. Okay, and then you have STEMI, which is an ST segment elevated myocardial infarction, and you can only diagnose that with a 12-EDKG because of the words ST segment elevation. It's literally a diagnosis based on an EKG along with the patient's symptoms and presentation. All right, continuing on with your history taking, your common chief complaints in the patients experiencing ACS include several different things: chest discomfort, dyspnea, fainting, palpitations, fatigue, but probably the most prevalent would be chest pain or discomfort. It's often the presenting symptom in somebody with acute coronary syndrome. And the description of the discomfort is for assessing its significance. We'll ask those OPQRST questions, and we know certain things about the quality. For instance, if it's a more of a pressure or a squeezing, that's more pathognomic of somebody experiencing a myocardial infarction. Whereas if it's more pleuritic in nature or sharp, that may be more indicative of like a pulmonary embolism or a pleurisy or something like that. However, there's no like hard fast rules when it comes to those things. If the patient has more than one chief complaint, ask them, which symptom started first, which bothers him or her the most, because these associated symptoms can also be a good indication of what's happening. And then also remember dyspnea. It's a super important chief complaint that can be indicative of an acute coronary syndrome, especially if it's unexplained. Now, if they have a history of COPD with wheezing, most likely where the cause is for that dyspnea. However, if it's an unexplained dyspnea that they have like at rest, you should think cardiac until proven otherwise. Okay, unexplained dyspnea that they have at rest, think it's cardiac until proven otherwise. Get your 12-EDKG, do all of your cardiac stuff, especially in your postmenopausal women, your diabetics. These patients have atypical MIs, so they might have an atypical presentation, meaning it's not your normal presentation. When it comes to dyspnea, it may vary in intensity. It's difficult to assess because it's a symptom and not necessarily a sign that you can see. It's hard to get objective information about the dyspnea. Ask the patient to rate the severity on a scale of 0 to 10, even with shortness of breath. Dyspnea that develops suddenly suggests a pulmonary embolism, right? We know sudden onset of dyspnea is a pulmonary embolism until proven otherwise. So sudden onset, pulmonary embolism until proven otherwise, and dyspnea at rest should be an MI until proven otherwise. It could also be a pneumothorax or an acute pulmonary edema, pneumonia, airway obstruction. So do all of your tests, listen to your lung sounds, get your patient's temperature, do all these things. And get a good assessment. Dyspnea that occurs on exertion or at rest suggests COPD or a left ventricular failure. Right? So that's more of an explained dyspnea, where you're unexplained. Remember, think cardiac. Paroxysmal nocturnal dyspnea, or PND, is a sudden onset of difficulty breathing in which the patient suddenly awakens from sleep. It's associated with left ventricular failure because they might actually get pulmonary edema in the middle of the night. They'll wake and it usually happens about 2 to 4 hours after they go to sleep. They might feel better after they stand up for a few minutes. It's often accompanied with coughing, wheezing, sweating. They could have obstructive sleep apnea, which also causes it. And a good question would be, how many pillows do you sleep with at night? Are you more tired throughout the day because they're not getting enough sleep at night? These kinds of things help you with your assessment. They also have a feeling of suffocation upon awakening, and it usually improves, like I said, after about 15 to 30 minutes of standing, and then they go back to sleep. So that's your paroxysmal nocturnal dyspnea. If your patient has a cough, then find out whether the cough is productive or if it's dry. If your patient has fainted, try to determine whether the patient fainted from a cardiac or non-cardiac cause by doing an EKG, looking for arrhythmias, or increased vagal tone, if they were on the toilet and that's why they fainted. It's very common. The most common cause of syncope is by far dehydration. So make sure that they've been getting good intake of fluids and provide fluids in most of your patients anyhow. Consider a cardiac cause if fainting occurs in the recumbent position, is provoked by exercise, is associated with chest pain, or is a family history of fainting or sudden death is present. So think cardiac with those things: recumbent position, exercise, chest pain, family history. And it's important to consider that possibility because your sudden unexplained death victims, the patients that end up having Brugada syndrome or long QT syndrome or something like Takotsubo cardiomyopathy, you don't have to memorize that. All of those patients often present first with syncope, and it goes unrecognized. So keep that in mind with your syncope patients, that it could be cardiac, and always do a 12 lead on every syncope patient you have. Patients with cardiac problems may present with a chief complaint of palpitations, and it can be caused by anxiety, lack of sleep, certain medicines, caffeine, stress, of course your illicit drugs like cocaine or amphetamine, heavy cigarette smoking even, metabolic conditions like hyperthyroidism. They can have a thyroid storm. Changes in the heart rhythm or rate, including fast rhythms, tachycardias, and early beats, such as SVT. SVT is very common, especially in females, especially when they're menstruating because they're anemic, and it makes sense that they would be in some sort of compensatory tachycardia, and then they go into a re-entry tachycardia. So your SVTs often present with palpitations as well. So ask about the onset, the frequency, and the duration of the symptom in the previous episodes of palpitations. If it's SVT, your patient often knows that they have a history of it, and a lot of times they can even get themselves out of it with a quick vagal maneuver. Ask about the presence of associated symptoms such as chest discomfort, dizziness, syncope, and dyspnea, if they passed out, if they're short of breath. These are all important things. Fatigue is a common complaint in patients with impaired cardiovascular functions as well. Fatigue is a tough one because it's a symptom and not a sign. And ask when the patient's fatigue began and how long it's been present. Also ask about associated symptoms such as chest discomfort, nausea, dyspnea, syncope, or palpitations. Patients may also report a variety of other related symptoms, including the feeling of impending doom, which is a bad one, right? We know that feeling of impending doom can be ominous. Nausea or vomiting, trauma involvement, hypoxia. Inquire about pertinent aspects of the patient's other medical history that will kind of clue you in on what's going on. Of course, ask about the medications, but ask also, is he or she taking medications that are prescribed for someone else? You got to know your common cardiac medications, and they include the following, such as your antiarrhythmics, like Lanoxin or digoxin, procainamide, amiodarone, verapamil, which is a calcium channel blocker, your anticoagulants, such as anaxaparin, which is Lovenox, clopidogrel, which is Plavix, and warfarin, which is Coumadin. You have your ACE inhibitors, or angiotensin-converting enzyme inhibitors. And those are all your ILs or your PRILs, right? Your lisinopril, enalapril, captopril. Those are all your ACE inhibitors. Beta blockers such as atenolol, metoprolol, propranolol. So all your LOLs are your beta blockers. And then you have your lipid lowering agents, for cholesterol, like Lipitor or Lopid or Lescol, all of Crestor. All of those are going to indicate that the patient has hyperlipidemia or high cholesterol, which can put them at risk for an MI. You might have a patient that has diuretics like Lasix, and that's going to be your CHF patient. And when somebody's on diuretics, they could alter their potassium level. So you may have something else going on, an electrolyte disturbance due to a cardiac cause. Vasodilators, they could be on nitro, and sometimes people just don't know how much nitro they're supposed to take, and they may take too many sprays. So if they're hypotense and they just took a bunch of nitros, you might want to assess that. Ask about non-cardiac medications as well. So your over-the-counter medications, your phosphodiesterase inhibitors, like Viagra, Cialis, and Levitra, your ED drugs. You want to know about those before giving something like a nitrate. And then your herbal supplements can cause serious and even fatal interactions when taken with certain cardiac medications. So find out, if the cardiac medications that they're on, along with certain herbal supplements, can cause a really adverse reaction. And of course, recreational drugs can also be a concern as well. You're going to ask specifically about their medical history and if they've been diagnosed with any of the following: coronary artery disease, atherosclerotic heart disease, angina, previous MI, hypertension, heart failure, anything like that, valvular diseases, aneurysms, pulmonary diseases, diabetes, renal diseases, vascular diseases, inflammatory cardiac diseases, like your endocarditis, pericarditis, myocarditis, previous cardiac surgeries, your CABG, do they have a CABG scar, any of that? And then congenital abnormalities could also be at play. They could have a heart that's completely reversed, completely backwards, right? So you definitely want to know if they have, then that's called dextrocardia, situs inversus, if they have congenital abnormality that they know about. You're going to move on to your secondary assessment, and then the physical exam for a patient with cardiac complaints should emphasize the condition, the cardiac condition that they have. The skin color and temperature may indicate circulation problems. Mottled skin is, a bad sign of poor perfusion. Obviously, we know pallor and cyanotic skin, what they might indicate. Flushed, warm skin may be a sign of infection, such as pericarditis. They could be septic from that. All right, so the physical exam should also include an inspection of the neck and the tracheal position. All right, you're going to inspect the adjacent structures, such as the neck veins. Remember, to estimate your jugular venous pressure, you're going to look at the jugular veins. You're going to place the patient in a semi-Fowler position with the head slightly rotated away from the vein that you're trying to observe. And then you're going to look at the height of the distended fluid column in the vein. Okay? And then note how far up the distension extends above the sternal angle. Okay, so you're looking at how engorged basically that jugular vein is, and that'll let you know if they have a backup in their jugular venous pressure, meaning that the right side of their heart is not accepting blood. Meaning that there could be a right-sided heart failure, that could be cardiac tamponade, tension pneumothorax, any of these reasons where you have increased chest pressure not allowing the right side of the heart to expand. All right, moving down from the neck to the chest, you're going to inspect and palpate the chest, of course. Look for surgical scars indicating any previous cardiac surgery, your big zipper scar down the middle of the chest and indicating a CABG. Check for a nitroglycerin patch on the skin. Sometimes people forget they even have them on. That could be the explanation for syncope, low blood pressure, that kind of thing. Look for a pacemaker or an implantable defibrillator. Check for the chest enlargement or that barrel chest that you might see in a COPD patient. You're going to observe for any signs of crepitus, of course. Listen to the chest with a stethoscope. You're going to auscultate, and then listen for crackles, wheezes, anything that might indicate left ventricular failure with pulmonary edema. Then you're going to move down to the abdomen. You're going to inspect and lightly palpate that abdomen for distension and pulsations. Strong pulsations in the epigastric area may be a sign of a AAA, an abdominal aortic aneurysm, so that pulsating mass in the belly is not a good sign. And that patient, if that ruptures, that AAA, then they can become hypotense pretty quickly. Other signs that they might have a AAA, they could have tingling in one of their legs or both of their legs. A lot of times it becomes painful. You have that paresthesia where it feels like pins and needles in your leg, and if it keeps going, if you keep having no circulation to that area, it will become unbearable. So those patients, it's hard to keep them on the stretcher because they want to come off the stretcher. They're in so much pain. Check for swelling also in the patient's arms, hands, legs, feet, ankles, sacral areas. That's all an indication of ventricular failure. Bilateral pitting edema may be a sign of right ventricular failure. And we know pulmonary edema is a good sign of left ventricular failure. You're also going to use the monitoring devices like your cardiac monitor, EKG, get your 12 lead, get your capnography, your pulse ox, all of those things. And your pulse findings in cardiac patients can also be helpful as well. You want to determine if there's a pulse deficit, of course, difference between the apical pulse and the peripheral pulses, which would help you identify, changes in pressure. You're also going to check their blood pressure and check for something called pulsus paradoxus. Pulsus paradoxus occurs when the systolic blood pressure falls more than 10 millimeters of mercury with inspiration. And cardiac conditions in which this finding may be present include myocardial infarction, cardiogenic shock, cardiac tamponade is a big one, and constrictive pericarditis. So all of those can cause pulsus paradoxus. And then check for a beat-to-beat difference in the strength of a pulse. This is a pulsus alternans, and it may be a sign of a severe ventricular failure. Pulsus alternans often occur, when they have really bad pulmonary edema, and the respirations will actually change the pulse. Blood pressure findings in your cardiac patients, also in older patients, systolic blood pressure of more than 140 is a more important risk factor for cardiovascular disease than a diastolic pressure. A systolic pressure of 120 to 139 millimeters of mercury, or a diastolic pressure of 80 to 89 millimeters of mercury indicates pre-hypertension. All right, so basically below 140 and over 90. In emergencies, elevated blood pressure may be from anxiety or pain or just your presence. They have that white coat syndrome, so know that. Try to calm your patient, see if their blood pressure will come down with a little bit of calming and reassurance. Also, your systolic blood pressure lower than 90 millimeters of mercury may be a hypotension or shock. Not everybody's blood pressure is the same, and somebody could have a blood pressure of 120 and be hypotense for them, right? If they typically walk around at 150 over 90 and now their blood pressure is 120 over 80, that's hypotension for them. So keep that in mind. Also, some people could have a blood pressure of 98 systolic and be just fine. So consider the patient's presentation along with your findings. Increased pulse pressures may indicate arteriosclerosis, the hardening of the veins, and the plaque buildup within the veins. A reduced stroke volume may be a sign of cardiogenic shock or cardiac tamponade, of course, and if possible, obtain and compare blood pressure in both arms. Changes in the blood pressure in one arm and the other one of more than about 10 millimeters of mercury can be an indication of what we call a dissecting aortic aneurysm, where that occurs more like where I was showing you before, where the ascending aorta, the aortic arch, and the descending, aorta are. You could have kind of a bulge in that outer lining of the aorta, and it can burst, and you can get a change in blood pressure based on your left side and your right side, because those three big vessels at the aortic arch, that's where you get your blood flow to your arms. Your subclavians come off of that. So you might actually have a different pressure in one arm than in the other one. Continuing on with the physical exam, we're going to talk about assessment of the heart sounds. Now this intimidates a lot of paramedics, and they think it's pointless, but it is a clinical finding, and it's worth having some knowledge about. So your S1 sound is a heart sound. It's the first heart sound. It occurs near the beginning of the ventricular contraction, when the tricuspid and the mitral valve close. So when you're listening to heart sounds, usually what you're hearing is the closing of those heart valves. That's where that lub-dub comes from. The sound of the tricuspid valve closing may be louder in cases of hypertension. All right, so S1 may be louder in patients with anemia, a fever, or hyperthyroidism, as well as patients with stenosis of their mitral valve. Decreased S1 sounds can indicate fibrotic or calcified mitral valve, obesity, emphysema, cardiac tamponade. All of those things are going to cause a decreased S1 sound. A split sound from any delay in the closing of both valves is considered abnormal. Of course, if S1 is your first heart sound, then S2 would be the next one, your dub, if you will. And it occurs near the end of ventricular contraction when that pulmonary and the aortic valve both close. All right, so as the ventricles eject its blood and those pulmonary and aortic valves close shut, that's what you're hearing. And it's louder in patients that have a chronic high blood pressure or pulmonary hypertension, and it's going to be decreased in patients with hypotension. And it might be split when you have bundle branch blocks because, in the case of a right bundle branch block, you'll have a result in the delay of the pulmonic valve closing. And with a left bundle branch block, you may actually have a delay in the aortic valve closing. So you can have a decreased, or split sound in those cases. S3 and S4 are both considered extra heart sounds, so they're not normal. S3 is an abnormal heart sound that occurs in adults when there's ventricular wall vibrations that result from a rapid filling period of the ventricle during the beginning of diastole. All right, so during the beginning of diastole, when the heart's at rest, you'll get a rapid filling of the ventricle, causing these vibrations that you might hear as the S3 sound, and it's often associated, almost always associated, with heart failure. And then S4 is very rare, and it could be heard actually before S1, and it's caused by turbulent filling of blood in a stiff ventricle that could have been caused by an MI or LVH or something like that, like a post-MI type patient that has a stiff, not working very well ventricle. You might actually hear this turbulent blood flow. And then we have a heart murmur. A heart murmur is a sound that occurs from turbulent blood flow as well, but it's turbulent through the valves. So during your S1, S2 sound, you might hear some turbulent blood flow, and it's increased blood flow across a normal valve. And the flow across an irregular or constricted valve can also occur, causing a heart murmur, or blood flow into an enlarged heart chamber, like when you have LVH, RVH, or the atrial enlargements, or backward flow through a comprised valve. So when they have valvular regurgitation, or atrial regurgitation, that kind of thing, that backwards flow is going to be turbulent and sound like a heart murmur. And as always, we're going to finish up the assessment with potentially doing a reassessment, and it should be done on the way to the hospital if you're transporting your patient. And with that, we're going to end this first video of cardiovascular emergencies.